previously thought possibly to represent thyroid metaplasia in lymphoid tissue, and labelled lateral aberrant thyroid. It is now recognized that findings of differentiated thyroid tissue in a lymph node invariably indicate lymph node metastasis from a primary carcinoma of the thyroid, which is often small and occult. C is correct. The usual type of thyroid cancer to give lymph node metastasis is the papillary carcinoma, which has no familial tendency. Papillary thyroid cancer affects young adults of either sex and is a slow-growing neoplasm. Spread is predominantly via lymphatic drainage to midline pretracheal and metastatic thyroid cancer 1N lymph node prelaryngeal nodes in front of the thyrohyoid membrane, the latter called Delphic or oracular node because it is a predictor of an underlying but inapparent cancer. Spread also occurs to the deep cervical chain of nodes following superior and middle thyroid veins, and to nodes around the recurrent, inferior, laryngeal nerve and anterior mediastinum following inferior thyroid veins. The natural history of the condition is generally favorable and usually extends over many years. The lesion only rarely spreads beyond head and neck. Repeated operations for recurrent tumor can often contain the disease for years. Spread via the bloodstream is unusual, in contrast to the follicular and medullary types of thyroid cancer. So repeated local surgery for recurrences after primary surgery is worthwhile. Subacute, de Quervain, thyroiditis, thyroglossal cyst and Hashimoto thyroiditis have entirely differential features, and benign thyroid adenoma are confined to the thyroid gland itself.